First, a very brief roundup of the week's top stories from Physicians First Watch, read by editor Amy Herman, and then a chat with Dr. Don Berwick about his JAMA editorial on wasted U.S. health spending.
Hi, everyone. Here's our first story. A new study finds that roughly a quarter of the $3.5 trillion spent on healthcare in the U.S. each year is wasted. The top three areas of waste were administrative complexity, overpricing by drug makers and hospitals, and lack of care coordination. Next, the U.S. Department of Health and Human Services this week published a guide for clinicians on tapering and discontinuing long-term use of opioid analgesics. Among the recommendations, before beginning a taper, patients with serious mental illness or high suicide risk should be referred to a behavioral health provider. Elsewhere, the CDC reports that combined cases of syphilis, gonorrhea, and chlamydia hit an all-time high in 2018. Researchers note that condom use has decreased in some vulnerable groups, and budget cuts for STD programs have led to clinic closures. Next up, a meta-analysis finds that in patients undergoing coronary artery bypass grafting, or CABG, dual antiplatelet therapy with ticagrelor or clopidogrel is better than aspirin alone for preventing saphenous vein graft failure. The researchers calculated that 10 patients would need to receive aspirin plus ticagrelor, or 19 would need to receive aspirin plus clopidogrel to prevent one graft failure. And finally, the FDA is urging the public to stop using vaping products that contain THC, or any vaping product obtained off the street or from friends or family. Most of the cases of lung injury tied to vaping have involved THC. And that's it for this week. Stick around for Joe Elia's latest clinical conversation.
If the United States is spending $3.5 trillion on healthcare annually, and roughly $800 billion of those $3.5 trillion are characterized as wasted money, and healthcare economists have proposed strategies that could reduce that amount by 25%, the question is, why haven't Americans followed the advice of the demented news anchor in the movie Network and thrown open their windows to yell, "I'm mad as hell and I'm not going to take it anymore"? Don Berwick has an editorial in JAMA about that waste, and especially about the lack of dramatic movement to curb it. We'll let him explain it in a minute. Dr. Berwick is probably best known as a co-founder of the Institute for Healthcare Improvement, for which he serves as President Emeritus and Senior Fellow. He is at the origin of the idea of the triple aim in medical care, and he served as the administrator of the Centers for Medicare and Medicaid Services in the Obama administration. Welcome to Clinical Conversations, Dr. Berwick.
It's a pleasure to join you, Joe. Thank you.
Your editorial is delightful, I have to say, and it's also freely available on the JAMA site. So tell us a little bit, if you would, about the paper that you are commenting on.
This is a marvelous paper by Will Schrank and his colleagues. Will is now at Humana. He actually worked at CMS for a while, and I've known Will for years. What they did was try to replicate the findings about the magnitude of waste in American healthcare that appeared in about the year 2012 or so. There were three reports, one from the National Academies of Medicine, Institute of Medicine, one from the RAND Corporation, and then an article in JAMA that I co-wrote with a colleague named Andy Hackbarth. All three tried to estimate the magnitude of waste in the American healthcare system. We, in our 2012 article, defined 6 categories of waste. Schrank took the same 6 categories and updated the data using whatever resources he could find to come up with an estimate. He also took a step further, which is he looked for research on removing waste and tried to report back on the success and magnitude of those waste reduction efforts.
Yeah. And so you start off your editorial by mentioning Fermi's paradox, which is the question Fermi asked of his lunch buddies. If the calculations show that there must be other life in the universe, where is everyone? In your case, if the calculations show this much waste, why are we letting it sit there? So you go about answering this Fermi's medical paradox with 4 possibilities. So maybe if we step through them, we'll discover some interesting things. First, the first possibility is, well, the waste just isn't there. How do you respond?
Yeah. Well, that would be the argument that the research that has tried to determine what amount of non-value added activity is somehow flawed. These are massive numbers. The Schrank estimate is around 25% of all the money we spend, 3.5 trillion. 25% of 3.5 trillion is not adding value, even just in these 6 categories. And that's probably an understatement.
You said 300. I'm sorry, Doug. You said 300 trillion. You meant 3.4 trillion.
Oh, did I say? Yeah, $3.4 trillion. 25% of that, in Schrank's conservative estimate, is waste. In the articles that he's drawing on from 2012, the estimates range between 30 and 35%. Our own estimate was 34% median estimate. This is a massive amount of money. I mean, it would, if you could somehow magically remove it, it would change everything. I mean, the country could have all the money it could ever want to do what it wants with infrastructure and education and social justice and healthcare. So it's enormous opportunity, and it is, in some sense, incredible. So the first question is it really there? And I would have to say, of course, I guess I'm conflicted a little bit because I did one of the studies, but all of the people that have looked have found it. So, and the numbers are remarkably similar. You might say, well, Schrank only said 25%. We said 34%. These are easily explained by variations in methodology. The point is, it's a massive number, and I just don't think it's tenable.
Yeah.
Scientifically, to say it's not there.
You point out that number of wasted money, the $80 billion.
800.
I'm sorry, that's right. 800.
Numbers are so large, we keep having to correct ourselves.
Right. The 800 billion that's wasted is equal to the size of it's greater than the size of Medicare and Medicaid combined.
Yeah, more or less. My budget, Medicare and Medicaid, when I was there, was 820 billion. So it's of the same order of magnitude.
Yeah, and larger than the entire Defense Department budget of the United States.
It's just massive. It's just massive. A massive amount of money, and there aren't any. And when you get to the more fine structure, so we all Schrank, and we use the same 6 categories of waste: overtreatment, use of care that can't help; failures of coordination, when you drop the ball and therefore costs go up and harm happens; failures of execution, when the care is unreliable and especially patient injuries occur from errors; problems of administrative costs, where we just have lots of hoops we're running through, paperwork and eroding time, productive time; pricing failures, where things that should be commoditized or are commoditized, they still have boutique pricing, especially now with market concentration in some areas; and then last, fraud and abuse. So those are the 6 categories we looked at. So even within the categories, you can find supportive evidence that there are problems.
Yeah, and one of the explanations for the inaction that we see is the second possible explanation is maybe that money just can't be extracted.
Yeah, the analogy is maybe it's marbled like fat in meat. You know, there's no scalpel you could possibly use to dissect it out. On its face, some of that is incredible. Take administrative waste. What do you mean? I mean, we have, incompatible operating systems. We have multiplicity of billing forms. You can't tell me you can't get rid of that. That has to be a will problem, but it's not a scalpel problem. It's not marbling that's a problem. For other things, you could argue, well, it just comes with the territory. But, I don't believe that, number one. My career has been spent largely helping organizations try to find this and successfully reducing costs. Waste reduction is a well-known enterprise in every other industry. It can be in healthcare. And then Schrank adds heft to the counter argument because he actually finds many examples of organizations or systems that have worked on components of that, elements of that waste, especially in the areas of overuse and medical error and reliability.
And you say another possible explanation is maybe the problem's not interesting enough.
Yeah, there's no will. Maybe people just don't really want to remove it. I think that's more plausible. It is. I mean, if you want to be a little conspiratorial about it, which I don't frankly think is a particularly powerful way, but you could say, well, look, even under current payment systems with things starting to change, overuse of machines, turning the MRI machine on more than it's actually needed, is lucrative. It makes money. Arguably, even medical errors can. Certain kinds of injuries to patients result in higher needs and higher revenue in organizations that are trying to keep their beds full. Reduction of administrative paperwork is a matter of, it would be very inconvenient for insurance companies to have to all change their billing forms now so they come into alliance. It's kind of easier not to. For pricing failures, look, if I can get, insulin prices in this country are going up every quarter. There are now 25%, I believe, of people who require insulin have to cut back on their own dosages because they can't afford it. That's money being made. That's a lot of money changing hands. So the will to find the waste, it may be deficient. We just don't have a health economy that makes it, for most, interesting to find it and root it out.
And your comment on that was one of my favorite comments in your delightful editorial. Was it's what some economists call waste, others call income.
Indeed, and it is. I mean, we have to. There actually is a little bit of empathy to have here. Let's take the administrative burden, which is probably the largest single pot of the six anyway.
Yes.
Those are jobs. Those are people, clerks and paper processors and employees in hospitals and insurance companies and clinics. They're actually paid to maintain that administrative structure. I don't think they're human beings. They're people. They have needs, and so we shouldn't be glib about those dislocations. So yeah, somebody's waste is somebody else's income. That's one of the reasons it makes it hard to change.
Yeah, you say that maybe, and I think this is probably how you would explain it. Politics paralyzes change.
Yeah, that was my fourth and I think most powerful explanation. It's a little bit sophomoric in a way to propose it as an answer, but it is actually what's happening. That when you pick any particular component of wasted effort, let's take overuse of procedures, there will be someone whose ox is gored. The people who are making the MRI machines that are being overused and the radiologists that are using them. If you want to work on coordination of care, you're going to have to force organizations to spend time working with each other, which they could be used for other revenue generating activities. In other words, the politics are pretty set up against this right now. It's a funny politics because if we could remove and reinvest the waste, the proportion of society that would gain vastly outnumbers those that would lose. Mm-hmm. But those that lose are the ones that are mobilized. Yeah. And we know the amount of money spent on lobbying on Capitol Hill for the status quo is very large. And when I ran Medicare and Medicaid, believe me, it was part of my life every day to take phone calls from people who would say, oh, no, you won't. That's my area, or you're going to hurt us. And they'd call their congressman or the senator or the White House, and those calls would come back. So it's real. It's very real.
You end your editorial with thoughts about the corrupting power of money, as we were just talking about, and your observation that the solution to the problem will, and I'm quoting here, require both awakening a sleepy status quo and shifting power to wrest it from the grip of greed. Pretty strong stuff, but that's what it is. I guess you would maintain, and I guess everyone wants as much money as they can get their hands on, up to a certain extent. But that's where we are, isn't it?
Yeah, on the sleepy status quo. This, of course, was written for JAMA's audience, clinicians, and one of the cases I'm making, and actually Schrank's paper has some supportive findings in it, are that if the physicians and nurses and pharmacists and the managers in healthcare wanted to take this seriously, they are in a position to do something about it. That's the sleepiness, which is, this money is really actually hurting other people when it's used on waste. I call it confiscation. And so don't we want to stop it? I commended the American Board of Internal Medicine's work on choosing wisely, but that's a rather low voltage campaign right now, but it could be amped up. There could be clinicians could say, we're going to stop this. We're going to work really hard to stop wasting money. So I say, please waken. And then on the grip of greed, it's quite real. I mean, the big evident, the thing everybody knows about is pharmaceutical pricing now, which is really, really hurting people. And that's just get all the money you can stuff. Is the same happens with equipment, the same is happening with pricing by hospitals in highly concentrated markets.
Yeah, you actually mentioned that that pricing is maybe outpacing pharmaceutical pricing in some areas.
Yeah, there are good research on this, and the drivers that you're noticing. In fact, we just have evidence even in my state, Massachusetts, of both pharma pricing going up much faster than the rate of inflation, and in some markets for some kinds of hospital pricing just going up much faster. Huh. That is a matter of market control. I mean, that is really well known to be associated with concentrated markets.
What do you hope, modestly, that your editorial and the article that you were commenting on will accomplish?
Well, one is for clinicians, a return to purpose. I mean, this waste hurts people. It hurts patients and families, and we're here for patients and families. So I continue to have a lot of faith and a lot of respect for the ethics and conscience of our professions. And I think I'm just saying, hey, guys, harm is being done. Why don't we get together and stop it? And I think, I guess maybe that sounds naive, but it doesn't feel naive to me. I know these people. I know they're my friends and my neighbors and co-professionals. So let's get about it. At a societal level, I'm more political about it. This is harm. This is a real confiscation in which, governors who need money for schools and those businesses that need money to pay their employees more or to do more R&D or compete globally, and agencies that want to have more funds available to help people of disadvantage and people that are arguing about infrastructure. These needs for that money are enormous. And so some part of me says, well, gee, if people really could become aware of this and get together, politically mobilize, there could be quite a demand for change that I would welcome. I must say there's one thing not in the editorial, though, that does shadow this for me. It casts a shadow, which is although the waste is there and should be removed and is hurting people, I will not support at all any argument that says, therefore, we take money away from the safety net. There's a toxic argument here that could be used to say the hospitals that are serving the poor, disadvantaged communities, disadvantaged minority communities need to use their money better and not waste it, and say, yeah, but we still need policies that give support to those organizations that are doing their best to deal with inequity in our society.
Thank you very much, Dr. Berwick, for talking about this rather complicated issue and about your editorial, which I hope a lot of our listeners will now read.
Thank you, Joe. Total pleasure.
That was our 238th episode. The whole searchable collection is available free at podcasts.jwatch.org. We come to you from NEJM Journal Watch. The executive producer is Kristen Kelly. I'm Joe Elia. Thank you for listening.